Morning, everyone. Thank you so much for joining us again today for our reinstatement of the Global POCUS Collaborative after a summer break. I really am so excited. We are so excited today because we have a really special person with us here today. Dr. Sarwal is kind of the person who has led the charge in neuropocus in the United States and now across the world. She is a thought leader in point of care ultrasound, particularly as it relates to neuro ultrasound. She's a professor of neurology at Wake Forest University and the co-director of the ultrasound curriculum there. If you're in the Society of Critical Care Medicine, you've probably seen her face every month as she recaps all of the important, really landmark papers that are coming out in critical care. She is on guideline papers for point of care ultrasound, and she lectures across the world. And we are really so super fortunate to have her join us here today. So without further ado, Dr. Sarwal, I'll pass it to you and feel free to just take over.
I can't seem to share my screen.
Oh, let me see if I can make that happen.
Well, while you do that, perfect. Screen. And can you guys see my screen and hear me all right?
Yes, we can see your screen.
Okay. So thank you so much, Dr. Nikravan. I mean, you've been an inspiration yourself, and I hope there's no words I can express to show my gratitude on your advocacy and sponsorship for POCUS in general, and being part of such a great collaborative, and just humbled and honored to be part of this outreach. I do think ultrasound has significant capabilities of providing medical diagnostics to low resource and otherwise low accessibility these places, and extending neurology indications of POCUS as a part of whole body POCUS is something that I am really appreciative that people are endorsing and recognizing. So in the next 40 minutes, I'll give you a little perspective on basics of neuro ultrasound, assuming that some of you have never practiced neuro ultrasound. For others for whom it is a redundant topic, I hope you can give me some constructive feedback on better teaching strategies. I know I don't have any relevant disclosures. I do have some device loans from vendors for supporting one of my investigator initiated trials, and except for educational conflicts, nothing really more. So when I talk about neuro ultrasound, in general, if you've heard other neuromonitoring talks, everybody has kind of a framework around which they talk about neuromonitoring. When I think of any neuromonitoring modality, I kind of think of two things. Number one, there is not a single modality that can really serve everything in neuro assessments. You really have to combine different aspects. And the second part is I look at the brain as a house. So in a house, you have the structural component, you have the plumbing component with the pressure of the water, you have electrical component, and then you have these other miscellaneous elements like chemistry of the house, the drywall, the air, and everything else that runs the house. So when I think of the brain as a house, when I'm looking at a patient from the perspective of pathophysiology behind their acute brain injury, I tried to figure out what's wrong with their structure, what's wrong with their plumbing, what's wrong with their electricity, what's wrong with their air. And then when a patient has progression of the disease or acute neurological decline, this framework also helps me figure out what explains the patient's decline. And if that doesn't explain it, what else should I be ordering? So if the plumbing problems, too much blood or not enough blood explains the pathophysiology, great. If not, then I look at other compartments. From an ultrasound perspective, interestingly, the ultrasound actually helps you figure out all four compartments to some extent, and I'll give you a little perspective of that today. From a structure component, you can use ocular ultrasound to look for papilledema, optic nerve sheath diameter. I'll touch on that briefly. You can look at midline shift assessment as a surrogate for cerebral edema. So these are structural evaluations that can be done with ultrasound. obviously we will focus a lot on the plumbing component, the actual cerebral blood flow and cerebral blood flow velocity assessment, which can also help us assess the distal vascular bed resistance. That is a major factor in considerations with intracranial pathology. Surprisingly, when you have electrical issues in the brain, too much blood flow can actually be a surrogate for something like seizures. Again, you can't take this in isolation, but that's where having blood flow assessments can help you. And then obviously autoregulation assessment, which is the vascular bed's response to systemic hemodynamic changes that can be assessed with transcranial Dopplers or neuroultrasound. So why would you use ultrasound when we have CTs and MRIs? Well, first of all, even in the most resource-rich settings, access to CT, MRI may not be as universal as we think. Sometimes because of economic factors, sometimes because of patient factors. The patients are too sick to be transported, patients on high ventilator settings, there is systemic instability, or our traditional neuromonitoring devices are not accessible to the patient, like patients on anticoagulation that need invasive intracranial pressure assessments, but we can't just place a monitor because of anticoagulation, thrombocytopenia, or some induced or systemic coagulopathy. And obviously, in austere environments, resource-limited environments, ultrasound is kind of naturally a non-invasive point-of-care tool that is way more accessible than other traditional neuroimaging and neuromonitoring devices. So we do have a skull that fortunately protects the precious brain. And the skull by itself, while protecting the brain, really doesn't allow us access to look inside it compared to the rest of the body, especially in pertinence to ultrasound. But the good thing is, despite having a tight skull, there are certain windows in that skull that can help us look through the brain. The positive it is, it allows us access. The negative it is, these almost are like windows in a warehouse. You have to use that small window to make a judgment of what's inside and kind of scan across. So the three major windows we talk about, the classical is the temporal window. So when we think about our temporal bones above the ears on both sides, the area between the tragus of the ears and the lateral canthus of the eyes, that area by itself has thin enough bone where it can allow access through ultrasound. We call them temporal windows. So this is your temporal window. Then we can also get access to the posterior part of the brain through the foramen magnum, and that we call the occipital window. Then through the orbital fossa, we can see the ophthalmic artery and sometimes the ICA siphon, internal cerebral artery, internal carotid artery, and that's called the orbital window. And then only in one particular disease process, we look at the extracranial internal carotid artery. It's actually not a window to the brain because we're only looking at the outside the brain part of internal carotid artery, but that can be useful as well. And we're traditionally using the echo probe, the same probe that you use for echocardiography. We're using that for TCDs as well, 1 to 3 megahertz probe. You can use the abdominal probe as well, but preferentially we use the phased array probe with the index marker towards the eyes. People use, I will be basically discussing point of care applications of imaging ultrasound, but people have been using non-imaging Doppler in transcranial applications for quite some time. The principles of image acquisition and the waveform interpretation are the same. It's just that here we have B mode and here we don't. So if we didn't have the skull, ultrasound can actually provide you pretty nice views of the brain. So here you can see the patient is hemicranie. We are putting the patient's ultrasound probe on the side of the hemicranie very gently, without much pressure, index marker towards the eyes. And with this orientation, the eyes will always be on the left side of the screen and the occiput on the right side of the screen. So this is the eyes, this is the occiput. You change the depth to allow the opposite skull to be visible. So typical depth would be 13 to 15 centimeters. And in this case, you can see the falx cerebri, the frontal horns of the lateral ventricle, the third ventricle, and the choroid plexus in the temporal horns of the ventricle as well, and the different gyri sulci across the parenchyma. And this is vasogenic edema, with concordance to the CT scan, where you can see the hemorrhagic conversion of an ischemic stroke. So that's if you didn't have the skull. If you do have the skull, then using these temporal windows, you can still see significant structures, and you can definitely see enough blood flow to get Doppler assessments. So again, we put this low frequency probe, phased array probe on the temple, and depending on your patient, 85% of the patients do have thin bone in the temporal area. Some have the bone maybe the size of a penny. Some have pretty big windows. It's variable. 10 to 15% people will have thick skulls where there would be no temporal windows, at least on one side. So you can still try both sides before you say the patient has no windows. Males in general, sorry people, older people have thicker skulls and lesser windows compared to females and younger people. So once you put this here, you kind of do window shopping. You move around your probe until you can find a window. And when you know that you found a window, you'll be able to see the opposite skull. That's the most landmark structure visible, provided the depth is adjusted to deeper than the width of the skull, approximately 13 to 15 centimeters. And then if you align your probe up and down to the base of the brain, you will be able to see this butterfly-shaped structure. This is anterior, this is posterior. So this butterfly-shaped structure is the midbrain, or top of the midbrain, where you can see the peduncles and you can see the colliculi. You will see a lot of white fluff around it. This white fluff is typically the arachnoid that is present in the basal cistern. And then on the ipsilateral side, you can see the bony ridge that divides the anterior and middle cranial fossa. This is made of the sphenoid wing of the temporal, the petrous part of the temporal bone and lesser wing of the sphenoid, but we'll just call it sphenoid wing for the sake of being able to say it easily. So you take the low frequency probe, you found your window, make sure you orient yourself anterior posterior, index marker will always be towards the eyes. You find the opposite skull, you find your inner butterfly, everybody has one. And just like people, these butterflies come in all shapes and sizes. And then now we are going to explore looking at the blood flow by looking at circle of Willis with color Doppler and pulse Doppler. Before we do that, one of the hallmarks of B-mode ultrasound, which can be extremely useful in point-of-care applications, is looking at midline shift assessment. So just like you look for midline shift assessment in the CT scan, you're going to image the skull in the axial section. This is the opposite skull. This is your midbrain. This is your falx cerebri, and this is your cerebral aqueduct. Once you have imaged the midbrain, you calculate the distance from the ipsilateral side to the midline structure, in this case, the third ventricle, and then from the third ventricle to the opposite structure. The caveat to remember here is, just like a CT scan gives you axial sections, this midline is being done in the axial section, but because of the angle at which you get the window, this may not exactly correspond to the CT scan. The correlations between midline shift measured on the ultrasound and the CT scans are about 0.8 to 0.9, based on the few studies that have done it. Serial assessments help more than actual values because you can't get exactly the quite same angle that is horizontal as a CT scan. The other caveat you have to remember is that the midline shift structure, the midline structure that you choose to measure the midline shift needs to be relevant to the patient's pathology. So in this particular case, we are looking towards the vertex. So you can see kind of the curve of the occiput. You can see the falx being a little bit skewed. So here we're looking very close to the top of the skull, and we're looking at the falx cerebri, and the posterior part of the septum pellucidum is the midline structure because the patient had frontal pathology. If the patient has deep temporal pathology, you would rather choose something close to the midbrain like the third ventricle or the pineal gland. But if you're choosing the septum pellucidum, it needs to be frontal pathology. The other part is some people do measure midline shift from one side first and then the other side opposite. The only caveat to remember there is that the lines will not exactly measure up the same because these are not the same horizontal sections. So keep that in mind. Again, serial assessments help more than the absolute assessments. So this is a pictograph that shows midline shift assessments at the septum pellucidum level, then at the third ventricle level, and you can also do it at the pineal gland level, which is another hyperechoic structure visible posterior to the midbrain. So the next thing you will do is do color Doppler. So in this case, we have the B mode. We have the opposite skull. We have the butterfly here. With these are the cerebral peduncles. This is the colliculi. And this is your sphenoid wing. And this area in front of the midbrain is kind of your pituitary fossa with this white fluffiness. And here you put on color Doppler with the positive Doppler shift red and negative Doppler shift blue. And you're looking at middle cerebral artery, anterior cerebral artery. This is the opposite circle of Willis, and this is your posterior cerebral artery on each side of the midbrain. Again, horizontal section at the level of the basal cistern. You can't quite get the same section like you're used to seeing on a CT angio, but once you identify the midbrain and posterior cerebral artery and middle cerebral artery in relation to that, then you can identify the other structures one by one and kind of build up the circle of Willis in your perspective. So once you've identified the circle of Willis, so in this case, we have done, this is the midbrain, that's the fluff around the midbrain, and PCA would be a little bit immediately around the midbrain, and a little bit anterior to that would be the anterior cerebral artery going away from the probe. You can see the blue signal here, and middle cerebral artery going towards the probe, which is the red signal. Now that you've identified the middle cerebral artery, I'm going to put the pulse Doppler gate. This is the all vascular ultrasound is pulse Doppler. You define the gate, typically 5 to 10 millimeter, because that's the width of the intracranial vessels. And I'm putting this pulse Doppler gate in the distal middle cerebral artery at the depth of 3.2 centimeters. And then I'm getting the spectral Doppler waveforms. The spectral Doppler waveforms here are low resistance waveforms. So if you're familiar with vascular ultrasound, this is your cardiac cycle, just like an arterial line, just like your telemetry screen. This is your systole, this is your diastole. Systole, diastole. Diastole is twice as long as the systole. And the classical waveform in the low resistance circulation is rapid upstroke. Brain likes to get all the blood, doesn't want to let it go. Stepwise deacceleration. A robust diastole, that is a third to half of the systole. So this level, which is about 40, is third to half of the systole, which is about 90 in this case. And you can see these measured here as well. Vital organs in the body, which is brain, coronaries, kidney, liver, and placenta, all have low resistance circulations, which look like these waveforms if you were to do a pulse Doppler, because they want to get preferential blood in the times of sepsis, hypotension, extremis. The hallmark of low resistance circulation is at no part of the cardiac cycle does the blood flow go to baseline. So there's positive blood flow always throughout systole and diastole. You can measure ipsilateral vessels, and you can also measure contralateral vessels through the same window in case you can't get the opposite window where you're looking at the opposite skull. Here is kind of the midline, and here you're putting the pulse Doppler in the opposite MCA, pretty deep, 10.2 centimeters, and you can see the Doppler waveforms here. So qualitatively, these are low resistance waveforms. The waveform shape is pretty classical, rapid upstroke, stepwise deacceleration, robust diastole, that is third to half of the systole. We can also look at the peak flow velocity and end-diastolic velocity, but the number we use most commonly in quantitative waveform analysis in transcranial Dopplers is this time average mean flow velocity, which is technically area under the curve. It is a time averaged mean of the max velocity at each point. It's kind of the same as MAP as well. If you don't have a software to calculate mean flow velocity as area under the curve, you can use the MAP formula, just like you calculate MAP from peak systolic and diastolic blood pressure. You can use the same formula for MAP, but preferentially, you want to use the software to calculate the time average mean flow velocity. We also use this other number called the PI, and PI is a number that is calculated by peak minus end diastolic divided by mean, and this is an index of distal cerebrovascular resistance. And it's just the same as the resistivity index that you use in renal literature. When your resistance is pretty high for the blood vessel that is supplying the vascular bed, it'll be very high, more than 1.2, 1.5. If the resistance is very low, then it will be less than 0.5. The normal velocity, mean flow velocity of intracranial circulation, is about double digits. There are age-based normative criteria that have been published that you can refer to. But for point-of-care applications, if you can remember that double-digit velocities are good, triple-digit velocities are bad, and signify some pathology. For pediatric population, these velocities have very variable age-based criteria. So there, I would highly recommend, even for point-of-care indications, please use the published age-based normative criteria before you use velocity for pediatrics. But for adults, we'll stick with double digit is good, triple digit is bad. So we use these velocities, plus we also use this number PI. Now, the one caveat to PI and velocities is that these are very sensitive metrics. Velocities can be very high because there is too much blood flow in the brain, or the blood vessel is very tight, and that's why the velocities are up. So very sensitive, but not very specific. Similarly, pulsatility index is also very sensitive, but not very specific. If your patient has very tight blood vessels at baseline because of distal atherosclerosis or advanced age, or posterior fossa in general compared to the anterior fossa vessel, have tighter blood vessels compared to the anterior, so their PIs could be high at baseline. So having a baseline can be extremely helpful. If you have a baseline in your patient, then acute changes in pulsatility index could be a manifestation of intracranial pressure, which basically increases distal cerebrovascular resistance. So in the next few slides, let's go over a few qualitative ways we can look for these resistance patterns and how we can use this for point-of-care indications in the acute setting. Everything that I'm going to discuss in the next few slides will assume that the patient had a low resistance waveform at baseline. So this is your low resistance waveform, which is rapid upstroke, stepwise deacceleration, robust diastole, positive flow throughout the cardiac cycle. This is your systolic part. This is the diastolic part. When your distal cerebrovascular resistance goes up a little bit high, now this resistance could be focal because of a stenosis or thrombosis. This could be global because of increased ICP. The diastolic component is going to get compromised first. So the upstroke is still rapid, but the downstroke during systole becomes pretty rapid as well. So brain gets the blood but loses it, and there's barely any diastole. And then if the resistance increases even further, the diastole gets even more compromised. So in the early and the late part of the diastole, you don't see any blood flow, and sometimes even reversal of blood flow. And the systole becomes sharper and narrower. So these are different grades of resistance: high resistance, a little less resistance, and then low resistance. If you want to learn more about why the waveforms change the way they more and get yourself more accustomed to waveform analysis with regard to cerebral hemodynamic assessment, I'll refer you to the Spencer and Reed curve, which is was initially created for carotid stenosis, but has been validated for intracranial arterial changes as well, which basically describe how the blood flow changes, which is the area under the curve for these waveforms, and how the velocity changes in response to changes in the lumen, which may be caused by focal stenosis or by extra mural resistance as caused by increased ICP. So looking at the big perspective, this is a nice low resistance waveform. A little higher resistance waveforms, diastole is getting compromised. Very high resistance waveforms where there is forward flow during systole. So the heart is sending blood to the brain during the systolic phase, but the intracranial pressure is so high that during diastole, the brain is sending that blood back to the heart. So this is oscillating waveforms. And this progression of the waveforms can be a qualitative way to look at increased ICP in serial assessments. If you had focal resistance, immediately after the area of stenosis, you can see parvus attardus waveform, just like you see that in aortic stenosis. So if it was focal increase in resistance, you will see normal resistance waveforms, high resistance at the area of stenosis, and then post-stenotic waveforms called parvus attardus. If you have global increase in resistance, you don't see parvus attardus waveforms. All you see is normal waveforms going to high resistance waveforms and very high resistance, and then blood flow gets obliterated. So now that we've looked at the qualitative assessment of these waveforms, let's talk about a few clinical applications. Now, transcranial Doppler has a myriad of applications in cerebrovascular assessment, mostly in acute ischemic stroke, Moya-Moya disease, vertebral steel phenomena, sickle cell disease, shunt assessment, focal intracranial stenosis grading, and collateral assessment in bilateral carotid stenosis. These clinical indications need a little more understanding of cerebral hemodynamics, and I would encourage you to seek more resources if you're interested more in these applications. Here, I would focus on the point of care, acute care applications, mostly in subarachnoid hemorrhage, cerebral edema assessment, where I think especially in anesthesiology, emergency medicine, critical care, it can change paradigms for taking care of patients. A little bit of brain death assessment, which obviously is an unfortunate endpoint of malignant ICP crises, and a little bit of microembolisms, which can be very useful point of care tool in assessing patients' pathology. So let's first talk about subarachnoid hemorrhage. Now here we are only talking about aneurysmal subarachnoid hemorrhage, where the aneurysm has been clipped or coiled, and now you're managing the patient in the acute settings to look for what we call as vasospasm or delayed cerebral ischemia. This is one of the hallmark indications where TCD screening can be very helpful on a daily basis. And here we are doing middle cerebral artery assessment on this side and anterior cerebral artery assessment on this side. And you can kind of make out that this will be your circle of Willis, and this will be your ipsilateral PCA. You don't quite see the midbrain on this side. This will be your opposite ACA. And I'm putting in red and blue just as they would be in the pulse Doppler assessment. And this would be ipsilateral ACA, flow away from the probe. And the distal ACA would be flow away from the probe both sides. And this would be your opposite PCA. In this particular case, you have a lot of aliasing. For people who are familiar with the phenomena of aliasing, it's an ultrasound artifact. So lots of aliasing here. This would be your opposite MCA. This would be your opposite PCA. This would be your ipsilateral ACA. And then this would be your ipsilateral MCA, ipsilateral PCA, and opposite ACA. So in this particular case, you can see the middle cerebral artery is 188 centimeters per second. And remember, we talked about double digits being good for adults and triple digits being bad. So this is pretty high velocity. Now, with this high velocity, you can see the PI is less than 0.6. So this is a patient that technically has hyperemic waveforms. And you can kind of make an assessment with the area under the curve that velocities are pretty high, but the diastole is pretty high in relation to the systole as well. And that's what PI basically represents. In the ACA as well, you can see that the velocity is more than double digits, 113, but the PI is normal. So how do you figure out with this patient with subarachnoid hemorrhage, say the patient was day 6, whether this is vasospasm and you should be giving some vasospasm specific therapy, or this is hyperemia? This pattern makes you think it's hyperemia, but to make it easier, because we can't be doing qualitative assessments all the time, we can do what we call as Lindegard ratio. And what we do in the Lindegard ratio is we basically do the temporal windows and look for middle cerebral artery velocities. And in this particular case, you can see the velocity is 214 and the PI is 0.9. And we're trying to figure out if this is hyperemia or vasospasm. But then we do extracranial internal carotid assessment with the same probe, where the velocity would be going away from the probe. And the ratio of these velocities is called as Lindegard ratio, ipsilateral MCA to ipsilateral ICA. And we've seen that when this ratio is less than 3, you're more likely looking at hyperemia as the cause of intracranial vessel elevation. But if the velocity is more, Lindegard ratio is more than 6, then it's definitely spasm and very severe spasm. 3 to 6 is kind of in the middle, where it could be spasm of variable degree, but there could be some component of hyperemia as well. If you follow the TCD course, the time trajectory of TCD elevations are actually pretty predictable and do not show a change in management strangely, and can be very sensitive to kind of help you figure out that if the patient is day 6 to day 14 and the velocity is still elevated, you should still be monitoring them for vasospasm. There are published criteria for different grades of vasospasm, both on the velocity as well as Lindegard ratios. And you can refer to this publication and multiple other ones that have been published. There's a very nice systematic review as well from CCM in 2018 that talks about the value of transcranial Dopplers. Now, as you're monitoring these patients, you can incidentally see these spikes. You can see these white spikes coming up. These are called high intensity transient signals. Transcranial Doppler is so dynamic and sensitive that if your patient is actively throwing emboli in the brain, whether it's from cardiac source or a carotid source, you can physically see them happening. So if you see them, it's great to recognize them. A patient with infective endocarditis, a patient with carotid stenosis, a patient who has systemic bacteremia, If you see the embolic phenomena, that gives you an indication that active emboli are happening and whatever escalation of therapy is available. And for infective endocarditis, it may mean making the surgery more imminent in cardiothoracic population, or doing minimally invasive valvular extraction. For a patient with, say, a thrombus in the LV, and the patient was on low intensity anticoagulation because of bleeding risk, you might want to escalate anticoagulation, weighing the risks and the benefits. So looking at these emboli can be extremely helpful. And in patients with hypoxia, where the right and left shunts open, this can actually be a very good index of the grade of the shunt with the degree of hypoxia as well. So looking at the waveforms, let's talk about a few clinical applications of how you can use these waveforms in other indications in acute care settings. So just to reinforce, this is your low resistance waveform. This is a ultra low resistance waveform, which is actually a hyperemic waveform. And it's great to recognize that the PIs here will be very low. The diastole will be very high compared to the systole, way more than half. This can be seen in severe anemia or hypercarbia. So if your patient has CO2 narcosis, you can see very hyperemic waveforms, or systemic and cerebral vasodilatation, say with a nitroglycerin drip. So this is hyperemic waveform, normal low resistance waveforms. This is high resistance waveform. The diastole is much less than a third of the systole. The PIs would be more than 1.2. And this is ultra high resistance waveforms, or oscillating waveforms, where forward flow during systole is counteracted by negative flow during diastole, and there is no net forward going to the brain. And this waveform, if it sustains with no response to therapy, will actually progress to cerebral circulatory arrest. You obviously don't want that. So let's see how we'll apply this on a daily basis. So again, serial assessments help because T3 is very sensitive. If your patient has distal atherosclerotic disease or is older, especially in the posterior circulation, you can see high resistance waveforms like this in a baseline in a completely normal patient. So whenever possible, if you know you're going to be using transcranial Dopplers on a serial basis, please try to get baseline. And if the baseline looks like this, you know that it'll be difficult for you to just use the resistance of the waveforms as a serial marker. But if the baseline looks like this, which is low resistance waveforms, normal flow velocity, double digits, normal PI, 0.6 to 1.2 is normal. Diastole is a third to half of the systole. So this all can be a very good marker. If this patient, say, doesn't have an exam or is confounded by sedation, you come back tomorrow, velocity is still the same, but look at the waveform resistance now. This will tell you that the patient's distal cerebrovascular resistance has increased. If it's a global phenomena, everywhere you insonate, ACA, MCA, PCA, that's increased ICP. If it's a focal phenomena, something focal has happened in the vessel that you're insonating that is causing this increased resistance, which is typically caused by thrombosis or spasm. And this is another higher grade where the systolic part is reversed in the late part and diastole is even further. And you can use this as a target for therapy. So your patient's ICP goes up. You don't have an ICP monitor, but that's what probably happened based on the patient's pathology. Say they have a bleed and the waveform goes from here to here. And if you give the patient more mannitol, more 3%, or you do a decompressive hemicranie, and the waveform returns back to normal, that means you've normalized the patient's ICP. So not just for serial assessment, but can also be a target for therapy. This is what people have described and actually validated with multiple other neuromonitoring modalities. The progression to cerebral circulatory arrest can happen if the patient doesn't respond. So low resistance waveforms where ICPs are normal, high resistance waveform where ICPs are approaching the diastolic, but there is still forward flow during all parts of the cardiac cycle, systole and diastole. And remember, any forward flow during diastole is not consistent with brain death. That's something you can still salvage the patient. You can still escalate therapies. If patient does not respond and the pathology progresses, this is what we call as oscillating waveforms, forward flow during systole, backwards flow during diastole. This oscillating waveform, if not reversed in real time, can progress to systolic stumps and eventually cerebral circulatory arrest. If you have suspicion that this patient has progressed to malignant ICP crises and cerebral circulatory arrest, you cannot use the absence of flow as the only parameter if this is the first time you're looking at the patient, because 10 to 15% patients may have no temporal windows. So again, if you have a patient, early assessments, if they show that there was a temporal window And now serial assessments have shown this progression can help you say that this patient is now unsalvageable. So this would be another way of using these waveforms. Say you have a patient that you just got unresponsive, found down, you resuscitated the patient systemically, and patient is not waking up, and you look at their waveforms. Everywhere you see the waveforms are oscillating waveforms, forward flow during systole, backward flow during diastole, without having any other neuroimaging modality. If the patient's systemic blood pressure is now restored and is in the normal range, map of 65 and above, systolic is more than 100, then these waveforms tell you that the patient's ICPs are not compatible with survival if you don't have a salvageable injury underlying and the patient doesn't respond to therapy. This is another way. The first day you see this patient is low resistance waveforms. Next day you come back, high resistance waveforms. The patient's ICP has increased. For people practicing in ICU settings, even if the patient has an ICP monitor, this can be a very direct surrogate of the patient's cerebral perfusion pressure, and can help you find patient-centric ICPs. This personally was a case that I took care of, where the EVD was being weaned in a subarachnoid patient with poor exam. There was no change in exam. We were doing serial monitorings for vasospasm. Patient's ICP changed from 9 to 18, which in our algorithms will not be a trigger for therapy. Our trigger for therapy is about 20. But in this particular patient, the resistance changed so dramatically. So the patient is telling you that my perfusion is not normal at ICP of 18. I need it to be lower. So we actually dropped the ICP to 15, where the diastole was restored. And that helped us figure out that this patient needs ICP of 15 to maintain their cerebral perfusion pressure. Another way we use this is, even if you had an EVD monitoring, this is a pediatric patient with H. influenzae pneumonia that was on VV ECMO, and patient could not get EVD transduction because of the oscillation of the HFO. But we were able to use TCD waveforms despite such a confounder to calculate non-invasive ICPs. So you can look how the waveforms are a little more resistive over time, and we were able to titrate osmotic therapy to keep the PIs to be between 0.6 and 0.12 in all the blood vessels, and the patient was eventually extubated and did relatively well compared to the pathology that he had. And having that non-invasive surrogate of ICP was able to help us continue osmotic therapy, despite HFO not being able to allow us EVD-based assessment. This was a case where I used it incidentally. This was not as planned, but I was able to see how patients' waveforms responded to treatment. This was a aneurysmal rupture patient where the aneurysm ICA origin had ruptured into the temporal parenchyma, causing a temporal hematoma. So we knew the patient was going to get temporal evacuation because ICH was pretty significant. She had a good exam. And as the exam was deteriorating, her waveforms were still pretty low resistance. But just before she was supposed to go to the OR, her exam had deteriorated a little more significantly. GCR had dropped from 14 to about 8. And I saw the waveforms to be very resistive. And when she came back after evacuation, which was a craniotomy, the skull was replaced back. She was a young patient. The waveforms post-operatively were still pretty resistive. So we were able to use this to say that we need to continue patient osmotic therapy. And she actually got normal. She did not have an ICP monitor because of having a good exam initially. And we were able to use TCDs to continue osmotic therapy until TCDs came back to normal. And that's when we weaned the osmotic therapy off. Incidentally, she also had on the ocular ultrasound papilledema, which I'll talk about in a few slides, and high optic nerve sheath diameter as well, which were both surrogates for non-invasive ICP as well. Another example where I think ultrasound can be extremely helpful is cardiopulmonary resuscitation in cardiogenic shock patients. So no matter what modalities are you using, this is a patient that was elective aneurysm repair with thoracic surgery and had an intra-op cardiac arrest, was placed on VA ECMO and Impella and a balloon pump at the same time. And you can see the 2:1 cardiac pulsations here. One is from the patient's native heart and one is from the patient's Impella. Now, the point I'm trying to make in this particular slide is, look at the amount of vasopressors and inotropes this patient is on, in addition to mechanical circulatory support. If you were resuscitating this patient, you would like to know that the brain is getting perfused. And in this particular case, you're seeing oscillating waveforms, and there is literally no further escalation of devices here. So this can be a very good marker that your systemic resuscitation is not meeting its end organ goal. And this is a patient that actually progressed to cerebral circulatory arrest, massive cerebral edema, and passed away in 6 hours. compared to other patients where you can see the positive diastole restored, where that can be a good marker that your end organ perfusion is being restored with mechanical circulatory support. Future studies hopefully will elaborate more clinical algorithms, but I find this a very useful way of making sure that my brain is being perfused when I'm systemically supporting a patient. And if this patient obviously does not respond to therapies, and you need to use an ancillary test to declare the patient brain dead because they have confounders, TCD is a valid ancillary test provided you've performed the physical exam, you've attempted the apnea test, and both of them have been attempted, and they're confounders that you can use them for declaring a patient. So these oscillating waveforms and systolic stumps are two waveforms that are acceptable criteria for saying that this patient meets the criteria for brain death. If you do use TCD as an ancillary test, please review these guidelines. These were written in 1998, are the only published guidelines valid internationally. They still stand the test of time and are valid, that go over the technical considerations of use of TCD for brain death assessment, especially if you're using this in ancillary test. It cannot replace physical exam. You still have to attempt it, but it can be a good surrogate for showing that the patient has cerebral circulatory arrest if they have confounders. The only two waveforms that are consistent with the diagnosis is the oscillating waveforms and the systolic stumps, provided they're less than 50 centimeters per second. Absence of waveforms itself should never be taken as a definite unless you have already shown a progression of these waveforms with intact temporal windows, because the first time you do this and there is no flow, it could be just no windows. So I hope that these kind of few perspectives help you understand how TCD can be an extra tool to screen a patient for the presence of malignant cerebral edema by showing that these have high resistance waveforms. You can use this to measure cerebral perfusion in suspected cerebral edema patients, whether you're doing systemic resuscitation or following the patient's trajectory. And these waveforms can actually be a target in goal-directed therapy, and resistive changes can help you figure out whether you can de-escalate or escalate therapy in many of your patients. This is kind of a very, what I call a bread and butter way of how I use point-of-care assessment with transcranial Dopplers in patients for initial evaluation, for increased ICP evaluation and ECMO patients, and especially if you have a blown pupil and how to use it to triage. By no way this is a validated algorithm, but gives you a little thought process on how to use it that you can review when you get this resource slides baseline. And lastly, let me go over a few other indications of neuro-ultrasound in general, which I do consider ocular ultrasound to be a part of it. This is what your fundoscopic correlate of ultrasound, which is papilledema, where you can see the lamina cribrosa going into the vitreous humor. The same way you will use papilledema in other clinical assessments, you can use it here as well. The caveat here to remember is presence of papilledema is not an acute indicator of increased ICP. And we do not know the trajectory of how long does it take for the papilledema on the ultrasound to resolve, or how fast does it resolve, or how fast does it come and go, or how does it respond to therapy itself. So presence of papilledema tells you that the patient has had an ICP crisis. It just doesn't tell you whether the ICP is normalized or not. The same way you can use it for pupillar assessment, especially if the patient has orbital pathology or anaphylactic shock with angioedema that doesn't allow you access to pupils. So you can see pupillary reaction in the transverse axis, and you can also do M mode on this as well. And many of you are familiar with the optic nerve sheath assessment, where you can actually do the width of the optic nerve sheath diameter as a non-invasive surrogate of ICP. The cutoffs have been 5.5 to 6 millimeter, depending on the study you read. The caveat is serial assessments help more than absolute assessments. And if your ICP increases suddenly, it just goes from, say, hemorrhagic expansion of an ischemic stroke, it goes from 5 to 45 in a matter of few minutes. You may have normal optic nerve sheath diameter because the ICP increases so fast, it cuts off the basal cistern, doesn't have time for the CSF compartment to equilibrate with the optic nerve sheath. So typically, the only time you will see optic nerve sheath diameter widen with increase in ICP, when the trajectory of ICP increase is a little bit slow. So keep that in mind. There are lots of good systematic reviews published on optic nerve sheath diameter as well. Again, serial assessments help and have a good image standardization technique. Lastly, especially for austere environments and pre-hospital settings, I'm personally investigating the possibility of using cranial ultrasound for hemorrhagic diagnoses diagnose of ICH itself. At this point, it is still an investigatory modality. By no means has this been established, but my hope is in the next few years, you will see some more work come up. Technology needs to catch up with a little bit, but you should be able to see fresh bleeds. So if the bleed is very fresh and you have to learn the topography of cranial beam mode ultrasound, there are lots of posterior enhancement artifacts. But once you get used to it, very fresh bleeds can be diagnosed. And people have actually looked at ICH volume assessments using ultrasound when you're able to see the ICH. The ICH needs to be big. It's only supratentorial and fresh ICH. After about 5 days, you can't see the ultrasound appearance of the ICH itself. But more to come on this one. This is my ongoing study. We're doing it in the pre-hospital settings. The one caveat I will tell you is many people ask me about hydrocephalus assessment. People have published third ventricular assessments, lateral ventricular assessments using ultrasound. I would highly caution you not to use that until you are really familiar with cranial topography. There are lots of artifacts that produce these parallel lines that can be mistaken for the third ventricle in patients. So my humble request to anybody who wants to explore this is that use the published resources to really get used to the cranial topography before you use this in clinical setting. And at this point, I would caution against using it in point of care unless you really are an expert in it. Lastly, neuroultrasound can be a great addition to whole body ultrasound. So many of you are familiar with using point of care ultrasound for cardiogenic shock assessment. This is a stress-induced cardiomyopathy patient where the patient's EF is low, and we're using inotropes to titrate their cardiac output. The same way we use PEEP titration strategies with B-line assessment to look for pulmonary edema and how it responds to PEEP titration or even diuresis or dialysis for that matter. The same way you can use TCD waveforms. So say you have a patient with a decreased intrathoracic compliance, they have pulmonary edema, you've titrated their PEEPs, and because they're still volume overloaded and you're dialyzing them, you are worried that their PEEP might be causing increased ICPs. Measure them with TCDs. You can see the waveforms, and as you titrate the PEEP from say 5 to 18 and the B lines disappear, look at their TCDs, and if the TCDs go from normal resistance waveforms to high resistance, you know that you've compromised the patient's CPP. In this particular case, you will back off the PEEP until maybe 15, maybe 12, where the B lines are still less than before, but your TCDs are restored to normal. So I think knowing that brain is the eventual target of all resuscitation, if you're practicing point of care ultrasound in the heart and the lung, why not extend it to the brain? These are a few resources if you're interested in knowing more about point of care ultrasound that we've published, and hopefully more resources will come. And I hope that this review kind of gave you a perspective that the waveform, just like everywhere else in the ICU or monitoring paradigms, tell you a story. You just have to know how to read them. This will be your high resistance waveforms. This is very high resistance waveforms. This is normal waveforms, different kind of normal waveforms. This is very hyperemic waveforms. This is your waveform in a VA ECMO patient, non-pulsatile. So the waveforms will tell you a story. You just know how to read it. So really appreciate the opportunity and happy to take any questions.
Dr. Sarwal, thank you so much for that amazing lecture. That I feel like every time I hear you talk about neuro ultrasound, I learn something new and am able to take something else, even in my patient population that may be different than neuro ICU, for example. I am looking at the chat just to see if there are any questions, and I haven't seen any pop up yet. Does anyone have any questions for Dr. Sarwal? We'd be happy to answer them. Also, feel free to unmute yourself and ask it in person if you're comfortable with that. I know that we have colleagues, even Dr. Bugrara has a neurocritical care fellow watching in from New York as well. Any questions from the group? So I have a question for you, Dr. Sarwal, a very basic question. When you're doing these sorts of assessments, it looks like the probe that you're using is a phased array probe. Is that correct? So the cardiac probe?
Yes. So the same probe that you use for your cardiac POCUS is the same probe we use for transcranial Dopplers.
Great. And can you just kind of explain to the group why that probe is the one that you pick, or why you would need that probe? And do you have to change any of the presets and any of the settings when you're using what's kind of more standard, a cardiac probe for a neuro assessment?
That's a great question, Sarah. So when you use the echo probe, most of the point of care ultrasound machines now have a transcranial preset. The transcranial preset is a little more higher power than the cardiac preset. It has a little higher MI and TI settings for those people who are familiar with these words, because the penetration of the ultrasound has to go through the skull. If you don't have a transcranial preset on your machine, say if you have an older Sonosite M Turbo from 1990s, you can still perform transcranial Doppler with the echo probe. The caveat is the cardiac preset doesn't let you have good insonation. So then I would recommend using the abdominal preset, but turn off the setting called THI, tissue harmonic imaging. It's a little technical thing for many people, but if you have an older machine without transcranial preset, use an abdominal preset with the echo probe, switching off the THI, which is an artifact reducing software, and you can increase the gain. When you're using ocular ultrasound, the pictures I showed when you do pupillary assessments or the papilledema assessments or optic nerve sheet assessments, you will typically be using a linear probe, the same vascular probe you use for your central line assessments. Please, in that assessment, pay attention if you have an orbital preset. Orbital preset typically has 10% power compared to systemic presets. So the MI would be almost 0.2, TI would be almost 0. The orbital ultrasound is a little more sensitive to ultrasound-related heat effects. So that's why the power needs to be really low. If you don't have an orbital preset for papilledema assessments, with a linear probe, then I would suggest the replacement preset closest to that would be the soft tissue, which has the lowest MITI, and reduce the time that you're spending on the ultrasound as much as possible. So that's the fun thing about ultrasound. Even if you don't have the exact technology, you can still use the technology with some modifications to assess your patient.
And when you're using the orbital, you're doing an orbital exam with a linear probe. Does it matter where the orientation marker goes on the probe when you're doing that assessment?
I think the orientation marker for orbital ultrasound, I always recommend to keep it concordant. You can do it at 12 o'clock, you can do it, but if you keep the axial right and left orientation on the screen the same as the probe, that typically helps you better assess the pathology, especially if you see incidental pathology. So the orbital ultrasound typically will have the index marker to the left of the screen. So keeping that to the 9 o'clock position or the left of the screen is ideal. For transcranial Doppler, it is convention as much as possible to keep the index marker towards the eyes. So the left of the screen is always the anterior eye part, and the right of the screen is always the occipital part.
Perfect. And then I have one more question for you. So, you had mentioned how using orbital ultrasound, for example, may not be the best modality for a patient with an acute, severe increase in ICP, because it takes a little bit of time to develop the papillary edema and the connection with the optic sheath that would allow for widening of the measurements that we're doing of the optic sheath. In your practice or in your experience, what is the best tool for an acute assessment of an acute increase in ICP? Because this is kind of the world that we live in as anesthesiologists. Things happen, and they usually happen in front of our eyes, and they happen very quickly. What would be the best modality of the ones that you've mentioned here today for that kind of assessment? And would you recommend, if there is a potential high risk for developing ICP issues, for us to just be getting baseline TCDs in patients before we start a case, for example?
So I think that's a great question, Sarah. In my personal practice, I have now become a big fan of your latter suggestion, which is anytime I have a patient, for me, POCUS is a part of their physical exam now. So getting a baseline transcranial Dopplers to establish presence of windows, to see their baseline resistance of the waveforms, and get a quick ocular ultrasound as well to make sure they have no pre-existing papilledema, and they have no pre-existing optic nerve sheath diameter elevations, which can be wide in a certain subset of normal population. So when I have the baseline, for me, if time permits, based on the patient's pathology, I always try to do all three things: papilledema assessment, optic nerve sheath assessment, as well as transcranial Dopplers. I typically will start with TCDs because that can help me titrate therapies a little bit more proactively compared to ONST and pupillary assessment. Pupillary assessment, I only leave it for when I have no access to pupils by traditional pen line assessment, or I really need to do quantitative pupillary assessment on a daily basis. But typically, I would do very quick MCA on each side, make sure that the waveforms are low resistance, and then go on to optic nerve sheath diameter and papilledema assessment. So it's always a combination of techniques, never a single part.
Thank you so much, Dr. Sarwal. Anyone else with any other questions? We have about one more minute left to pick Dr. Sarwal's brain. No pun intended.
Can people show me with a show of maybe hands, or put the smiley face? How many of you are going to go and practice NeuroPOCUS? Just to make me happy. Okay, I got one, Chris. I got Dr. Shalja. Thank you. I got 3. Okay, 3 converters. That's not bad. You already a POCUS expert in neuro. Yeah, but I do appreciate your sponsorship and advocacy for Nibras and his as well. I think you guys are, I don't know how to thank. I have no words to thank you for the leadership you've seen and shown in making POCUS accessible across the world. Perfect. Okay, 6. I think my day is done.
And then we have one more question. What probe do we use in pediatric patients? Does the probe change?
No, it's the same thing. Echo probe there as well. The only thing is that you have a little bit lower depth there based on the skull width, but the probe is the same, thankfully, in most pediatrics. Same with neonates, actually, surprisingly. But be careful of the velocity values. Don't over-interpret them. You have kids typically have very hyperemic waveforms, low PIs, and very high velocities. So please follow age-based criteria that has been extensively published.
So pediatric echo probe would be good.
Yes.
Perfect. Well, thank you all so much. If we don't have any other questions, that's time for us here today. We're so excited to have had you, Dr. Sarwal, here today. This was really amazing. These lectures are video recorded and should be available to us online on our YouTube channel. So you can just link to them there. The link is in all the emails that we send out. Additionally, we will have next month, Dr. Walters will be giving us a talk on point of care ultrasound for regional anesthesia and trauma. Currently the date is probably going to change from October 4th to another date, but we'll let you know ASAP what Wednesday morning that will be. Wednesday morning for our time here in Seattle, different times all across the world. Thank you so much, and I hope you all have a great day today, and come join us again next month.
Thank you guys for having me. Go practice ultrasound.
Perfect.